Now we'll go for the malignant lesions of the pancreas. What are the various malignancies of pancreas? The most common gene is KRAS. Okay, and most common histology is again pancreatic ductal adenocarcinoma. What is the most common cancer in esophagus? In stomach? Adenocarcinoma. Same way in the pancreas also it is adenocarcinoma. Okay. Yes, no?
Yes. Okay, sir.
Okay. So now look here. There is a term called periampullary cancer. Periampullary cancer. Okay. There is a term called periampullary cancer. It includes four malignancies, four different malignancies. See, duodenal malignancy. If the malignancy arising from the duodenum, D2, that is 1. A malignancy arising from the head of the pancreas, that is 2. A malignancy in the pancreatic duct or in the bile duct, 3 and 4. Okay, 1, 2, 3, 4. These all are grouped under periampullary cancer. Why is it so?
Surrounding the ampulla.
Sorry? Though their anatomical origin is different, that is, one is coming from duodenum, one is coming from pancreas, one is coming from bile duct. They all behave in the same way. Okay, clinical presentation is almost all the same. So treatment also is the same. So we call it as periampullary cancer. Is it okay?
Okay.
So there are these four cancers are there. One is cancer of the head of the pancreas, cancer of the duodenum, cancer of the bile duct, and cancer of the pancreatic duct. All these four cancers will have the common clinical features, common investigation features.
So you mentioned head of pancreas, duodenum, and what else?
Sorry?
You mentioned four of them, right?
Bile,
So
pancreas.
head of pancreas,
Just remember
duodenum.
this picture. No need to see. Head of the pancreas 1, duodenum 2, pancreatic duct, sorry, bile duct 3, and this ampulla. Ampulla is there here. Pancreatic duct and ampulla. This is 4. So only 4.
Okay.
Okay. So what will be the clinical features? The clinical feature is most commonly they will have jaundice, obstructive jaundice, because the bile duct is involved. Obstructive jaundice is there. Here, have you heard of this law before? Korweiser's law?
Yes, so.
You heard about it. Okay.
I heard of it.
Yeah. If CBD is obstructed due to calculus, the gallbladder is usually not distended. If CBD is obstructed due to malignant growth, the gallbladder is distended. I'll tell you an example. A 30-year-old male comes to me. A 50-year-old male comes to me. Follow clearly, please. 30-year-old male comes to me. A 50-year-old male comes to me. Both of them come to me with jaundice. Jaundice and abdominal pain. Jaundice and abdominal pain. Okay. Is it clear till now?
Yes, sir.
Yeah. I have done an abdominal examination. And the gallbladder is not palpable in this patient. Not palpable, negative. The gallbladder is palpable in this patient. Okay. So I will tell that this patient in whom gallbladder is not palpable, he is having no malignancy. It is not malignant. It is only due to stone, calculus only. In this patient who had a palpable gallbladder, I will tell that this is due to malignancy. This is not due to stone. This law is known as Korweiser's law. Why is this law? See, because if the patient is having stone, then initially there will be so much inflammation around the stone. So the gallbladder will not be distended. If there is stone, there is no distension because there is inflammation there. In malignancy, there will be distension of the gallbladder. So if the patient is having distension of the gallbladder, if I am able to palpate the gallbladder, then I think that that is a malignancy. Is it clear?
Okay, sir.
Others also, is it clear?
Yes, got it.
Yeah. So this is about the Korweiser's law. If the gallbladder is palpable, then it is a malignancy. If the gallbladder is not palpable, then it is. If the gallbladder is not palpable, then it is due to stone.
Only calculus.
Yeah. So here also the investigation for periampullary carcinoma is CECT. And here you have this important double duct sign. See, in this picture, ERCP or MRCP, you can see double duct. Normally it will look like a single duct. What I told you, this will come and open here, and the pancreatic duct will open here. The common ampulla of batter, like this it will be there. But here, see, there is of two signs. So it is of double duct. Okay. Yes, no. Double duct sign. Okay. Following.
Yes. Yes, sir.
So where do you find chain of Lake's appearance?
Acute pancreas.
Chronic pancreatitis.
Chronic pancreatitis. Where do you find double duct sign?
Periampullary cancer.
Periampullary cancer. Good.
Okay.
Okay. So now, what is the treatment of choice for periampullary cancer? It is Whipple's procedure. Whipple's procedure. Okay. Again, listen carefully. This is the duodenum. This is the pancreas. This is the bile duct and the pancreatic duct. Okay. So Whipple's procedure is removing the entire duodenum, the common bile duct, the head of the pancreas. This part will be removed. Okay. The entire duodenum will be removed. Head of the pancreas will be removed. Bile duct will be removed, and the pancreas, head of the pancreas and bile duct will be removed. So this is Whipple's operation. It is known as pancreatoduodenectomy. Head of the pancreas and the duodenum are removed. Duodenectomy. Okay.
Okay, sir.
Okay. So if you remove it, after that, how will you reconstruct? You will leave it like that, or you will reconstruct?
We have to reconstruct.
So what all you will reconstruct?
Pancreatic duct has to get into the jejunum or to the stomach,
Okay.
and bile duct is removed. So we'll also remove gallbladder, sir. No, right?
Yeah. We will not remove gallbladder.
Okay. So we have to connect this.
Sir, I think it is the pancreato-duodenojejunostomy.
Okay. So see here, you have, if you have done a Whipple's operation, this is what is left behind, isn't it?
Yes, sir.
So the liver is left, gallbladder is left, bile duct, part of bile duct is left, part of bile duct is gone, duodenum is gone, pancreas, head of pancreas is gone, stomach is left behind, jejunum is left here. This is stomach. This is jejunum. This is jejunum.
Could you just repeat again what we did and a little slow, because this was an question in exam, you know.
Yeah.
They gave the picture of it and asked what sort of surgery it was.
Yeah, I'll tell you again. Okay. We'll go a little slow then. Okay. See here, we are talking about periampullary cancer management. It is Whipple's pancreatoduodenectomy. So now this is the duodenum. This is the pancreas. This is the bile duct, and this is the pancreatic duct. Whipple's operation, we remove the duodenum completely, the head of the pancreas and the bile duct, distal bile duct and the pancreatic duct. These are removed. Okay. So what we are left with now, I just drawn a picture. What we are left with? We are left with the liver here, the gallbladder, the remaining ducts are left here, hanging. The stomach is lying here because duodenum is gone. The jejunum is here again. The remaining pancreas is here. Only head of the pancreas we removed. So this is what is remaining. Is it clear?
Yes, sir.
So I follow that we are removing the complete duodenum,
Yeah,
right?
we are removing the duodenum. Yeah.
Then head of pancreas is also removed.
Yeah.
Pancreatic duct is removed.
Yeah. Part of
And
pancreatic duct is removed. Part of the duct.
Okay,
Yeah.
and what else did we say?
Bile duct.
Bile duct. Okay.
Yeah, these parts are
Okay.
removed. So
Okay.
now what we have to do is we will anastomose this part to the jejunum. Hepatico-jejunostomy. We'll anastomose these two. Hepatico-jejunostomy. We'll anastomose pancreas to the jejunum. Pancreaticostomy. We'll anastomose stomach to the jejunum. Gastrojejunostomy. Simple, isn't it? So we'll anastomose the liver with the jejunum. That is the hepatico-jejunostomy. We'll anastomose the pancreas with the jejunum. Pancreatico-jejunostomy. We'll anastomose stomach to the jejunum. Gastrojejunostomy. GJ, HJ, PJ. This is what is known as Whipple's operation. Whipple's operation is not only removing, it is also reconstructing. Okay, this is more difficult than removing, isn't it? The hepatico, very tiny vessels, we have tiny ducts, we have to suture and anastomose. Okay, if this is clear, we'll move on to the next topic.
Yeah, I got it.
So
Thank you.
basically, we connect everything to the jejunum.
Yeah, basically we connect everything, whatever is left behind, we connect everything to the jejunum. Okay, simply.
Okay, sir.
This operation will take 6 to 8 hours normally. Okay.
Sir, in it is with the chain of legs, right?
Which one?
In chronic pancreatitis, we see
Chain of legs appearance. Yes.
In acute pancreatitis, is there is any signals there?
Acute pancreatitis X-ray, there are some signs like sentinel loop sign, colon cutoff sign, gasless abdomen. In X-ray, they are not specifically like this. They are not so important like this. Also, chain of legs is important.
Okay, sir.
Neoplasms and all. So there is, till now we have discussed about pancreatic tumors. Okay, and there are some tumors like neuroendocrine tumors. Neuroendocrine, there is belonging to the endocrine cells. Neuroendocrine, pancreatic neuroendocrine tumors. So examples for that are insulinoma, gastrinoma, glucagonoma, VIPoma, somatostatinoma, PPoma. So many are there, but only important for us are insulinoma and gastrinoma. Okay, insulinoma, the insulin secreting cells will get tumors. Gastrinoma, gastrin secreting cells will get tumor. Okay, so we'll just see here. This is gastrinoma, tumor of the gastrin producing cells. So see here, this is a triangle. The gastrin producing cells are located in this triangle. This triangle is known as, anybody?
Is it Calitz triangle?
No, not Calitz. Calitz triangle also I'll show you next, but this is not Calitz. This is Passaro's triangle. Passaro's triangle. Okay, Passaro's triangle, it is something to do with gastrinoma. So here see the junction between the cystic duct and the common bile duct, junction of the head and neck of the pancreas, junction and third and second part of duodenum. In between, if you draw a triangle, imaginary triangle, this is. In between only you will find these gastrinomas. Okay. Okay, now yes.
Okay, sir.
Cystic duct and the common bile duct. Here, this is one point. Junction of head and neck. Here, this is the other point. Duodenum, D2, D3. This is the other point. If you join these three, in between you can find the gastrinomas. Okay.
1 second, sir. So the junction of cystic and hepatic duct, head of pancreas, and the duodenum.
Head and neck of the pancreas. Head and neck of the pancreas.
Okay.
Second and third part of the duodenum. And you're not, see, cystic duct and not common hepatic. Cystic duct and bile duct. Common bile duct. Okay.
Okay, sir.
Yeah. So they will, these gastrinomas are seen in Zollinger-Ellison syndrome.
Sir, what
Triangle of Passaro. Passaro. P-A-S-S-A-R-O. Passaro. Okay. So this Zollinger-Ellison syndrome, If the gastrinomas are there, it is known as Zollinger-Ellison syndrome, high gastrin secretion. If there is increased gastrin secretion, what will be there? What will the patient present with?
Ulcer, peptic ulcer.
Yeah, peptic ulcers. Very good. So remember, this is the most common pancreatic neuroendocrine tumor in men 1. Most common pancreatic endocrine tumor. What is men? I told you, and again I'll show you. Men is multiple endocrine neoplasia. Men 1 is the most common peanut in men 1. The most common site is duodenum 1, D1, duodenum 1, and there will be increased gastrin secretion and increased acid secretion. Okay. Suppose, see, normally what happens is a 35-year-old male patient comes to our OPD with abdominal pain. Suppose we give some proton pump inhibitor. Okay, we think it is an acid peptic disease, and we give some proton pump inhibitor. He will subside, then leave it. But if he's having recurrent pain like that, okay, then we have to think of something else is there. And then if you do endoscopy, and if the ulcers are not in the usual location also, if the ulcers are in an unusual location also, then we have to think that the patient is having some Zollinger-Ellison syndrome. Okay, he might have some gastrinoma. Clear?
So it is the unusual location also.
Yeah, ulcers at unusual location, think of Zollinger-Ellison syndrome.
What is PNET?
PNET is pancreatic neuroendocrine tumor. Okay?
Okay, sir.
Pancreatic neuroendocrine tumor. These are all various tests to do it. Just I'll give it in the notes. See, this is important. Men's syndrome. Multiple endocrine neoplasia. Okay, multiple endocrine neoplasia. See, there are two types like men 1, men 2, A and B. Okay, so in men 1, there is pituitary adenoma, parathyroid hyperplasia, pancreatic tumor. Okay, in men 1, these are same: pituitary adenoma, parathyroid hyperplasia, and pancreatic tumor. Is it clear? You have to mug it up. There is no other this one for us. You have to mug it up. 3 P's are there: pituitary 1, parathyroid, and pancreas. 3 P's, men 1. Okay.
Okay, sir.
In men 2A, there is medullary thyroid carcinoma. I was telling on that day also, medullary thyroid carcinoma, men 2A, and pheochromocytoma, men 2A. Parathyroid hyperplasia, men 2A. In men 2B, there are neuromas and marfanoid body habits, along with medullary thyroid carcinoma and pheochromocytoma. Okay, just see, 3 P's are there: 2P, 1M, 1P, 2M. This is a simple way to remember. 3 P's: pituitary, parathyroid, pancreas. 2P, 1M, that is parathyroid, pheochromocytoma, M is medullary thyroid cancer. And 1P, 2M, marfanoid habits, mucosal neuromas, and medullary thyroid cancer and pheochromocytoma. Just you have to mark it up, read once or twice, it will be easy only. Just remember this picture, you will remember it. Okay?
Okay, sir.
So here one question which I like to ask is, most common pancreatic tumor in men 1 syndrome. I told you pancreatic tumor, but most common in men 1 is